Hello, lymphatic guys all over the world. My name is Makoto Mihara, and I am from JR Tokyo General Hospital. This is our hospital. Today, I would like to introduce you to the lymphedema treatment that we are providing on a daily basis. In particular, I would like to discuss the ways we combine surgical treatment and the conservative therapy and the scientific data we have presented so far. I have summarized our 20 years FDA journey in 60 minutes. Lymphatic venous anastomosis. Please sit back and listen in a relaxed manner. Let's start. In regard to lymphedema treatment, I would like to discuss how far we have progressed in treatment over these 20 years and aspects that we are currently struggling with. We've been doing a lot of trial and error, so we believe there will be tips and tricks for lymphatic guys all over the world. Firstly, I would like to mention our philosophy that are important to us when treating lymphedema. That first is our mission, the second is our vision, the third is our core values. I would like to start by discussing our mission. Our mission is to eradicate the suffering of patients due to lymphedema from the world. The next is vision. By combining the examination, conservative therapy, rehabilitation, and surgery, our aim is to achieve the ideal form of lymphedema treatment. We aim to not only improve the form, but also to make functional improvements. Finally, there are the core values. It is our belief that a scientific approach is extremely important, and this underpins our effort to treat our lymphedema patients in the best possible way. This is our hospital, the JR Tokyo General Hospital in the center of Tokyo. It has more than 400 hospital beds. This is our JR company. The closest station is Shinjuku Station, which holds the Guinness record for the most crowded station in the world, with approximately 3.5 million people using it every day. It's our department, lymphatic surgery. We receive approximately 500 patients on an annual basis for first consultation on lymphedema alone. We also perform about 400 lymphatic venous anastomosis per year. This is our lymphedema treatment team. The team is led by one female and one male doctor, and also features a plastic surgeon, a vascular surgeon, a nurse, physical therapist, a pharmacist, a massage therapist, an occupational therapist, a clinical psychologist, a medical clerk, and at times trainees from other countries. It's an extremely diverse team, and this is its main strength. To talk a little about the way that the lymphedema teams links up with one another, problems may sometimes arise in such teams due to the difference in the viewpoints that may occur when staff with such different perspectives gather together. As this may destroy the team, we have set a rule. That is to give maximum priority to evidence and quantification. When planning treatment, we always discuss with the team whether there's any evidence for that, or has that been quantified, and we proceed with the medical treatment based on a common understanding and thinking, so that we all are pulling in the same direction. This is our teamwork. I would like to introduce myself. I was brought up in Miyazaki. Miyazaki is very rural, completely different from Tokyo, but I enjoy two different cultures. I'm 46 years old, real middle age. I want to continue performing surgery for another 40 years. I believe physical strength is very important for me. My current hobbies are running and tennis and supermicrosurgery. I only started playing tennis recently, so I'm just a beginner. But in the near future, I'm expert. From now, with the title of my personal experience and LVA journey with lymphedema treatment over these 20 years, I would like to discuss what is a 20-year journey and what will I do from now. I started my career as a surgical resident. I was involved in treating cancer at this hospital. At the time, I felt that the complications of cancer treatment were treated very, very lightly, and I just set out on the path of plastic and reconstructive surgery, where I could treat these complications rather than cancer itself. From 2004, I received training in supermicrosurgery from Professor Koshima at the University of Tokyo. I was so enthralled by the techniques taught to me that I decided to make it my life's work. My duties at the time involved treating amputated fingers, performing breast reconstructions and head and neck reconstructions, and so on. From 2008, I was increasingly involved in basic research as a research fellow at Harvard University and learned the importance of a scientific approach. Following that, I wished to focus on lymphedema treatment, so I moved to another hospital. At the time, the department was opened as the Department of Lymphatic Surgery rather than the Plastic Surgery Department. And I was able to specialize in providing lymphedema treatment. Patients visited from throughout the country, and the hospital became very crowded. There was a 7-hour waiting list for the outpatient clinic, and it was hard for patients to get their first appointment. Following that, I moved to the JR Tokyo General Hospital, where I am currently, and through collaboration with other facilities, we are not only able to eliminate confusion within the hospital, but we are also able to work with different treatment facilities. Here, we practice a treatment method that combines surgical treatment and conservative therapy. Currently, we perform about 400 LVA surgeries per year with our teammate, which I think is the largest number in Japan. We are also publishing from 7 to 10 scientific papers about lymphedema treatment in English every year. And another feature is that we have started collaboration with fitness club to provide weight control for our patients. I shall explain my academic activities to give the main ones here. I'm able to report that we succeeded in discovering the pathogenesis of secondary lymphedema. We also found that the ICG lymphography test is effective in diagnosing and treating lymphedema. The treatment of severe lymphedema in adults has been improved by lymphatic ultrasound. We are also, as a new challenge, developing and investigating the ways of treating pediatric lymphedema. This is caused by abnormalities in the lymphatic vessels of the lung, intestinal tract, whole body abnormalities, and so on. Please check our paper for details at PubMed or Google Scholar. I shall now describe my examination method. 20 years ago, doctors used only palpation to diagnose lymphedema and would operate based on that. This caused serious instability in treatment results, as lymphedema was sometimes mistakenly diagnosed in elderly patients suffering from diffuse edema or some other condition. Then, 15 years ago in Japan, ICG lymphography was introduced, enabling definitive diagnosis and treatment to be performed with a high level of accuracy. Additionally, the result of introducing lymphoscintigraphy about 10 years ago is that the pathology can now be understood, not only in localized areas, such as upper limb and the lower limb, but also systemically and in the chest and the abdomen. By using lymphatic ultrasound for the past 5 years, we have been able to greatly improve LVA's results, as this enables us to understand the condition of lymphatic vessels in even greater detail. In terms of surgery, as I'm a plastic surgeon, my main job is surgery. A combination of treatments, including LVA, is performed, as well as liposuction, elephantiasis radicalization, and lymph node transfer or lymph tissue transfer to regenerate lymphatic vessels. In terms of my team, When I first started treatment, I worked on my own rather than as a team. This developed significantly through the participation of female doctors. Additionally, a very warm atmosphere was created with the participation of members from many different professions, including nurses, physical therapists, occupational therapists, masseurs, medical clerks, and others. Further, we have been able to collaborate with doctors in other countries when providing lymphedema treatment, and this has enabled us to broaden our perspectives. The first thing we did for conservative therapy was to quantify the compression therapy method, whereas until that point, the elastic stockings had been chosen based on ease of wear and skin comfort. We were able to introduce a method of compression that grasps the specific compression requirements for each patient. Additionally, as the involvement of the rehabilitation department is now in full swing, we can now evaluate physical strength and analyze gait. This enables us to clarify what the patient will be able to do when providing occupational therapy. Recently, we have installed treadmills within the water, and this is being used to treat patients with both weak knees and lymphedema. We are also collaborating with fitness clubs to help give patients the confidence to return to society. Recently, with the rapid spread of COVID-19, there are many patients who are scared to come to my hospital. So by starting an exercise class online, we have been able to provide treatment in a fun way. In terms of medical cooperation, I believe that it is difficult to carry out the full course of lymphedema treatment in only one hospital under the current circumstances. Through our collaboration with external clinics that specialize in lymphedema and treatment centers, our patients who are in a stable condition can first receive treatment at the referral center. After that, they can return to our hospital if they need additional tests, surgery, or hospitalization. Additionally, we are not only focusing on reducing the size of patients' legs so that they can walk, and our approach also aims to resolve our patients' mental issues too. It is also necessary for us, therefore, to consult with clinical psychologists and mental health care psychiatrists. Many patients who visit our outpatient clinic are worried about obesity and are experiencing swelling. We have therefore teamed up with an obesity outpatient clinic and applying obesity treatment as a priority. The system we have established involves face-to-face cooperation between internal medical doctors, pediatricians, and radiologists. I have been promoting the treatment of lymphedema in this way for the last 20 years. In terms of how we will proceed moving forward, I personally started the lymphedema treatment as a single medical director, but I felt that led to a slightly biased approach. I formed a team, therefore, on a scientific basis, and considered that it was very important to work as a team when providing appropriate treatment. I would now like to discuss the main topic. I would first like to discuss the treatment and prevention of cellulitis and how far we have progressed. As I will discuss in the section titled Pathogenesis of Cellulitis and Lymphatic Surgery and Treatment, it's a big issue for patients when they develop cellulitis. They may have a fever over 40 degrees. It becomes difficult to have a normal social life, and this can be a major cause of reduced QOL. The results of our analysis and report in the previous study were that LVA surgery could suppress the occurrence of cellulitis. This was joint international research between Japan, Italy, and the UK. In conclusion, it was found that the LVA treatment could reduce the number of occurrences of cellulitis by approximately 1/8. Please check our paper. It's very interesting. I would like to discuss the 3 representative cases here. The first is a patient for whom cellulitis occurred approximately 12 times over the course of 1 year. The second is an upper lymphedema patient for whom cellulitis appeared 20 times over the course of 1 year. The third is a 19-year-old cervical cancer patient for whom cellulitis had occurred four times. Although I'm not saying that one course of LVA treatment would be a complete solution to all of these patients, it has been shown that frequent medical care can reduce the frequency of cellulitis incidents. Our success rate is currently 95%. That is, 95% of patients are able to lower the frequency at which cellulitis occurs through LVA. It's true, however, that no improvement are seen in 5% of patients. Therefore, we turn the focus of our analysis to these 5% of patients. In doing so, we found that patients with an extremely high frequency of cellulitis, or people for whom treatment or LVA surgery was difficult, had complications of bulbar lymphedema or bulbar lymphoid follicles. When applying bacterial culture at the site of these bulbar lymphatic follicles and multi-drug-resistant bacteria were detected, we discovered that these multi-drug-resistant bacteria were entering the skin via the bulbar lymphatic follicles, and this was causing cellulitis. Lymphoscintigraphy is highly effective for diagnosing genital lymphedema and bulbar lymphatic follicles. The picture on the left showed lymphoscintigraphy in normal circumstances. Under normal circumstances, a radioisotope is first injected between the toes. It then enters the groin lymph nodes on both sides, goes through the pelvis into the thoracic duct, and returns to the heart. In the picture on the right, the lymph nodes of a postoperative cervical cancer patient have been dissected in the abdomen. It was then found that the radioisotope injected between the toes flow into the bilateral groin lymph node and back into the genital area. This enables us to diagnose genital lymphedema and bulbar lymphatic follicles. To explain using an illustration, normally the process of lymphatic flow from the lower extremities enters the lymph nodes in the groin and returns to the heart via the pelvic region. In the same way, the lymphatic flow from the bulbar region normally enters the lymph nodes in the groin and then returns to the heart via the pelvic region. So what happens to patients who have had lymph node dissection in the pelvic region? The lymph flow from the lower extremities does not flow into the pelvic region via the groin area, and so flows back towards the bulbar region, and in doing so creates edema and lymphatic follicles. Pathological analysis revealed that there were numerous lymphatic vessels dilated just under the skin. In that sense, we learned that if we resected it and stitched it back together, it would recur at a rate of virtually 100%. However, we found that by combining resection and LVA treatment, the previous relapse rate of 99% or more can now be reduced by approximately 30%. In that sense, if we analyze cellulitis patients and find they have lymphatic follicles, we believe that the addition of resection can reduce the incidence of cellulitis to about 129 and allow us to be successful in controlling cellulitis. It's new data. Currently, due to the spread of COVID, it's difficult to receive appropriate treatment in an emergency room, even if you have a sudden fever. Given this scientific background, we recommend that patients with lymphedema who have frequent cellulitis are treated with LVA. I would now like to discuss the extent of our progress with upper extremity lymphedema. It is now possible to analyze lymphatic vessels in real time by analyzing them using ICG. In terms of treatment results, LVA treatment for upper extremity lymphedema is more successful than for lower extremity lymphedema. In early cases, we are able to bring the patient to stable known as sleep-free, where no pressure was applied. An increasing amount of medical evidence from both Japan and overseas suggests that preventive LVA or LVA immediately after lymph node dissection can reduce the frequency of lymphedema occurrence. I would now like to introduce how far we have come with post-mastectomy pain syndrome, PMPS. Nerve damage and pain after lymph node dissection in the axial are said to result in the phenomenon known as post-mastectomy pain syndrome. This person came to the hospital after being diagnosed with post-mastectomy pain syndrome. She was diagnosed with BAS8 and was in such pain that she would leap up merely being touched. When a lymphoscintigraphy was taken, it was found that the findings of skin reflux coincided with this pain location. These image findings revealed that there was no nerve damage, and it was concluded that the pain may be due to the edema. The pain improved dramatically after LVA treatment. In that sense, in the case of post-mastectomy pain syndrome, if the pain comes from the nerves, we treat the nerves. Whereas, if the source of the pain is lymphedema or swelling, we recommend treating the patient for lymphedema. It has been found that the pain in patients with lower extremity lymphedema can be treated well with LVA. Next, let us consider treatment for lower extremity lymphoria. This patient has primary lymphedema and refractory lymphoria due to severe obesity. The patient was in a highly problematic state when he came to us, with a large amount of lymphatic fluid that had been exposed for over several months. Towels became soaking wet after approximately 1 hour. Lymphoscintigraphy revealed that the skin reflux matched the location of the lymphatic leak. Therefore, before the skin reflux findings, we performed the LVA treatment. The lymphatic leak stopped several days after surgery, and they were able to make a full recovery. The patient was instructed to receive treatment at an obesity clinic to prevent relapse. We also provide facial lymphedema treatment. This patient's face became puffy and swollen after radiation therapy and bilateral cervical lymph node dissection following laryngeal cancer treatments. ICG was performed on this patient to identify the location of the lymphatic vessels and perform LVA treatment like this. As we did this, the internal pressure of the lymphatic vessels in the face gradually decreased, finally reducing to a size where they reach the facelift and the tightening stage. I have talked about many things at a fast pace. So let's break for coffee. A recent topic related to us is that we are currently streaming an online exercise class on YouTube aimed at lymphedema patients for weight control. Weight control is a very important factor for LVA results. This is the work of a physical therapist at our hospital. The content of today's lecture is also uploaded as a video, so please search for Makoto Mihara at YouTube. I would like to continue from what I was discussing before. I will now move on to explain the progress we have made in understanding the pathogenesis of secondary lymphedema. Check this paper for details. We found historical change of collecting lymph vessels after cancer treatment. I will explain how, after lymphedema occurs, after lymph node is dissected, the collecting lymph vessels change and lymphedema develops. From these illustrations, you can see a cross-section of collecting lymph vessels. The collecting lymph vessels changes in 4 stages, as I will explain. When normal, the collecting lymph vessels are flat and translucent. If the lymph nodes are dissected, internal pressure increases in the lymphatic vessels and they become more and more dilated. The findings here appear like atherosclerosis. If this state continues, this is called lymphatic sclerosis. Additionally, the internal lining of the lymph vessels becomes damaged due to high internal pressure, and more lymphatic fluid leaks outside from the lumen. As the hose is damaged, the more it contracts, the worse the flow becomes, so it needs to further contract. The muscles thicken and the lumen narrows, becoming stenotic. Eventually, it closes and the lymphatic vessels are completely unable to function. This is a mechanism by which lymphedema progresses after cancer treatment. The keyword is lymphatic pressure. A Polish physician Olszewski published a paper describing the diurnal variation of the internal pressure of lymph vessels in 1980. Dissecting lymph nodes, it was reported, causes the internal pressure of the lymph vessels, which are normally around 30 mmHg, to spike to 100 mmHg or above. Lymphedema patients feel pain or abnormal feeling due to this condition. I shall explain using a photo of the actual surgery on findings of lymphatic sclerosis described before. I shall start expanding from the left side. Under normal conditions, the lymph vessel will be flat and clear. As the lymphatic fluid comes, they will repeatedly expand and contract. If the lymph node is dissected, internal pressure increases in the lymphatic vessels and they quickly expand. The patient feels both pain and a sense of discomfort due to this swollen state. If this situation continues, the lumen may become damaged and lymph fluid is exposed from the lumen of the lymph vessels. Further, the walls of the lymph vessels thicken and gradually turn white. Eventually, they may become fibrotic and reach a state without the lumen itself, and this may become terminal. If we look at the histological findings, we can see in the second paragraph of the figure the findings of alpha SMA and see the way in which stains smooth muscle cells brown. The wall of the collecting lymph vessels becomes thicker and thicker as the disease progresses. The bottom part is called protoplanin, which stains lymphatic vessels and the cellular cells. This is highly active when the internal pressure is high, but it gradually deactivates and will eventually become inactive. This stage is called pitting edema, where lymphatic fluid swelling can be seen. The onset of lymphedema is what we call the stage where it starts to leak out. In fact, we have come to see that the symptom gradually progresses after the stage when the lymph nodes are dissected and there is high internal pressure. If we observe this in an electronic microscope, on the left is a normal collecting lymphatic vessel lumen. As the walls of this lumen gradually thicken, this can lead to stenosis and blockage. I will now discuss the treatment mechanism from the perspective of what I consider to be the ideal treatment for lymphedema. When performing conservative therapy, the mechanisms of treatment is simply to increase the lymphatic pressure. Normal lymphatic pressure, as discussed before, is approximately 30 mmHg. However, the pressure drops rapidly when the lymphatic endothelium is damaged. The conservative therapy in this reduced pressure state is to force the lymphatic fluid into the lumen with elastic stocking or bandage compression, and thus increase the internal pressure and make it flow. In this sense, it's a measure to increase pressure. The method of LVA, on the other hand, directly connects the vein and lymphatic vessels. The pressure in the veins is set to range from 5 to 10 mmHg. The internal pressure of the lymph is 100 mmHg or above. A pressure differential occurs when the veins are directly connected to the lymphatic vessels, and the internal pressure of lymph vessels drops to match that of the venous pressure. LVA, therefore, can be said to be a pressure reduction measure. As we just saw in the previous illustration, surgical treatment to lower the pressure of the lymphatic vessel should be chosen if the internal pressure of the lymphatic vessel is elevated. On the other hand, conservative therapy to raise the lymphatic pressure is a better choice if the lymphatic vessel pressure is lowered as a result of lymphatic vessel lining damage. In actual fact, the same patient can have both lymphatic vessel with increased intravascular pressure and a vessel with reduced intravascular pressure at the same time. In this case, a combination of LVA and conservative therapy is often the best course. A representative case of this is a patient who suffered severe lower extremity lymphedema and lymphorrhea after cervical cancer treatment. Although the edema itself was in a very bad condition, the lymph scintigraphy revealed that the lymph vessels were very dilated and functional. 2 LVA were performed to reduce the lymphatic inner pressure, and this course of treatment led to improvements in the patient's condition. This patient suffered from a pelvic lymphatic cyst after cervical cancer surgery. The lymph had nowhere to go due to the lymph node dissection in the abdomen. and this formed a pouch which continued to spread out more and more. As the lymphatic fluid accumulated, which can cause the onset of infection, the lymphatic flow coming from the lower extremities caused the lymphatic inner pressure increase in the lymphatic cyst, and therefore, after the LVA in the lower extremities, the cyst disappeared several days after surgery. This is the same treatment concept as for early-stage lymphedema patients. This patient has had the lymph node dissection in the abdomen. The lymphoscintigraphy revealed skin reflux findings in the lower abdomen and the medial side. When LVA was performed, the skin reflux findings decreased, and they did not require the use of a stocking at all. I think we provided a complete cure. I would like to discuss how we would go about treating very serious case of lymphedema. The point is that the power of the team is very important. We consider it is very important to combine surgical and conservative therapy. This patient was a female in her 50s who suffered from frequent episodes of cellulitis due to lower extremity lymphedema after cervical cancer surgery. We performed LVA first to prevent the development of cellulitis and followed this up with reinforced bariatric and conservative therapy to improve this situation. Cellulitis did not recur. This patient, on the other hand, was first treated with conservative therapy to reshape the leg and improve the function of the lymphatic vessels, subsequent to which we performed the LVA to maintain this condition. This patient was a 62-year-old female with secondary lymphedema. Her condition was extremely severe. She had undergone several rounds of LVA, had a lymph node transfer at other hospitals, but as no improvement was seen, she was referred to our clinic. The first things we did at our clinic were to perform lymphoscintigraphy and a lymphatic ultrasound. These were very important for severe lymphedema case. You can observe the lymph vessel valves on ultrasound. This is the actual lymphatic valve in action, and you can see the peristalsis of the lymphatic vessels. Even in these very severe cases, we only carry out treatment after first confirming in evidence that some of the lymph vessels are still functioning. After first performing conservative therapy, we then performed the LVA, followed by radical resection of elephantiasis tissue. Finally, the patient improved to the level where they were able to walk very, very fast. A recent case involved a patient suffering from bilateral severe lower extremity lymphedema. This person underwent compression therapy, rehabilitation, and elephantiasis radicalization first. Now, after a sustained period of rehabilitation, they have regained the shape of their legs using stocking and plan to have LVA in the near future.
もうちょっと高くはなるんだろうか。結構こう動くね。じゃあ一ノ瀬さんの方向いて。はい。で足分。よしよし。
じゃあまず私は10回から始める。
腹筋かなこれ。腹筋？腸腰筋？
Some patients do not respond well to LVA, and for such patients, we may also perform lymphatic tissue transfer or lymph node transfer to regenerate lymphatic vessels. From this point, I shall introduce them. I will use an example to explain the lymphatic tissue transfer technique. The patient in question had lymphedema of the left lower extremity, and this did not improve despite repeated LVAs. We therefore decided to take the lymphatic system of the right inguinal region to the opposite leg under the pubic skin and allow the lymphatic flow, which is the flow of the lower extremities, to flow into the lymph nodes of the right inguinal region. These are the preoperative and postoperative states. You can see the improvements. The next case is a lymph node transfer patient. The lymph node was taken from the left axilla and implanted in the right groin. This patient had a right inguinal lymph node transfer, and the postoperative regeneration of the lymphatic vessels is evident from the lymphoscintigraphy. By creating the new flow in this way and combining it with LVA, we are able to improve this situation. This is before and after operation. Recently, we have been implementing liposuction as a form of treatment with LVA. In the areas where there are no lymphatic vessels, we use the intraoperative ultrasound to aspirate and shape such areas. However, as such surgery requires preoperative self-care instructions and postoperative compression therapy, I will introduce the case of my most difficult patient. This patient suffered from primary lymphedema of the lower extremities with associated skylight thorax. This was a 92-year-old female with primary lymphedema. The patient had serious lower extremity edema since her first year of life. She gave up its treatment. The findings from the X-ray, CT, and lymphoscintigraphy as shown here. Her doctor was mostly concerned with the skylight thorax, but our proposal was to treat skylight thorax and the lower extremity lymphedema simultaneously. Firstly, this is a pathology we elucidated for this patient. For reasons unknown, this patient has dilation of thoracic duct and lymphatic vessels. When we apply the compression therapy or other trauma, this increases the pressure in the lymphatic vessels, and each time this causes the lymphatic vessel in the chest cavity, the lymphatic hypoplasia site, to rupture or collapse. This causes skylight thorax to build up here. The way we decided to treat this was to create a lymphatic channel by performing a retrograde LVA and antegrade LVA. Then, when we tried to perform the LVA on the A section, but milky discharge appeared, we stopped the LVA here. We carried out an incision to allow us to perform LVA at B. As the edema was improved, we were able to use the simple resection and elephantiasis radicalization after LVA. Skylight thorax did not occur post-operation. The patient's breathing function recovered, and she can live an active life. Immediately after the surgery, the patient was only just able to walk, but after carrying out walking rehabilitation was quickly able to walk more. The patient wanted to try various sports. She had previously given up on including soccer. And so in the first month after surgery, rehabilitation was performed using a soccer ball. The treatment now involves rehabilitation, including badminton and table tennis, and the patient is living a very active life. A new challenge we have embraced is the treatment of generalized lymphatic hyperplasia in children. This patient had a chylous abdomen and was suffering with right facial lymphedema, right upper extremity lymphedema, and right lower extremity lymphedema. As we believe LVA treatment may be effective for these patients, we are currently accumulating knowledge to that end. This is a separate case in which the patient was referred to us as a result of producing 700 cc's of milky ascites after cardiac surgery, which can be fatal. It was discovered that on injecting ICG into the extremities, the ICG medicine on the lymphatic system of the lower extremities reached the abdomen, and it became fluorescent 15 minutes later. Our hypothesis, therefore, is that there is a close relationship between lymphatic flow from upper limb and pleural effusion, and the lower limb and the ascites. And so, we are performing LVA in the lower extremities for these patients. We first make a skin incision about 5 mm before cutting the branches of the great saphenous vein and connecting the vein to the lymphatic vessel found there. It is connected using a 12-hole surgical needle. The lymphatic flow can be reconstructed using 5 or 6 stitches. For these patients, the ascites stopped. The drain was removed on the third day after the surgery, and the ascites disappeared completely after LVA. We analyzed the first 5 cases. In particular, we are deeply examining 2 cases in which surgery was ineffective. The important point is that chyle can be divided into 2 patterns, yellow discharge or milky discharge. The color suggests whether the lymphatic system is broken. I like to check our paper for details, but LVA is effective for cases of yellow discharge. ICG lymphography and milky tests are effective for diagnosing these patterns. It's time for a second coffee break. I hope that you can listen in a relaxed way. Just to let you know something about me, I ran in the Tokyo Olympic torch relay on July 20, 2021. Although the event went ahead without spectators, it fired up the whole country. I enjoyed. We are running short of time now, so as a final sport, I would like to draw some conclusions. I would like to discuss the progress we have made in lymphatic ultrasound. For microsurgeons, we will explain the history of ultrasonic research in 3 minutes. This video is by Yoichi Ochiai, a famous Japanese engineering scientist and artist. Using ultrasonic technology, he presents his works of art. This is very interesting. The first ultrasonic research was in the 1700s for birds, how to fly and how to secure plane. Ultrasound research was further accelerated by the sinking of the Titanic in the 1900s. When it hit an iceberg, it was thought that ultrasonic research could prevent the sinking of the ship. During the war, ultrasonic research has progressed to find military submarines. After the war, it became a peaceful use, now used with fish finders. Now it seems that it is possible to find a single fish instead of a school of fish. Around the same time, it began to be used in medicine. Initially, ultrasound devices are used to find brain tumors. After that, it is used to check the pregnancy status. In addition, ultrasound is used to observe the heart and vascular system. In 2011, the visualization of lymphatic vessels using an ultrasonic contrast medium, sonazoid, was reported. In 2015, Dr. Akitatsu Hayashi reported a method for identifying lymphatic vessels without a contrast medium. In 2018, we reported on the evaluation of the quality of collecting lymphatic vessels and their usefulness in LVA. We can evaluate the condition of collecting lymphatic vessels using lymphatic ultrasound. The important thing is to find diastolic collecting lymphatic vessel with elevated intralymphatic pressure. Ectasis type is good subject for LVA. The easiest way to distinguish is that the collecting lymphatic vessels lie under the superficial fascia. Also, the lymphatic vessels with stagnant flow are not colored by Doppler. For details on how to distinguish, please check the method called DCAPS, which is reported in the paper. We have many merits for LVA. This is our paper about DCAPS. Please check it. By using echo, it has become possible to evaluate not only the location of collecting lymphatic vessels and veins suitable for anastomosis, but also the quality of them before surgery. Lymphatic vessels run like dancing under the superficial fascia. You can distinguish between the subcutaneous vein and the lymphatic vessel very easily using DCAPS. 20 years ago, LVA surgery was a lower surgery with no veins or no lymphatic vessels. During surgery, the surgeons and the patients were very stressed. We used ICG lymphography and a lymphatic ultrasound before LVA surgery to ensure that veins and the lymphatic vessels are found. Even in cases where lymphatic vessels can't be found by lymphoscintigraphy, but good lymphatic vessels can be found by this method in about 18% of these cases. As you know, the use of ultrasound equipment has dramatically improved LVA performance. LVA has become a reliable operation. As a result, the surgeon's stress has disappeared. We compared lymphatic vessel images by various probes and company, Canon, Fujifilm, G, and so on. In particular, different probes will give you different depths of visibility. The location of the collecting lymphatic vessels depends on the patient's condition. There is no almighty probe, so try different probes. I also tried using an ultra-high frequency of probes, 70 MHz. You can see very detailed images. It's very good machine, but it turned out that the part with the depth of 2 to 3 mm looks best. I will explain it in a simplified manner. The 70 MHz probes has a good visibility of 2 to 5 mm depth, so I think it is very effective for early cases of upper limb lymphedema. The 17 to 30 MHz probes has a good visibility of 8 to 15 mm depth. Therefore, I think it is effective for lowering lymphedema. It is very important to use different echo probes for various situations. It's horses for courses. By applying lymphatic ultrasound, I think that preventive LVA will make a dramatic progress. We can zero patients suffering from lymphedema in the world. I would like to discuss something new about the ICG lymphography. We had injected the ICG only once in the first interdigital area and found out that lymphatic vessels are actually lymphosomes, and these are divided into many lymphatic lesions. This allows us to inject ICG at each of these points, and this leads to improvements in surgical outcomes. We are currently injecting the ICG in 3 places beneath the skin for upper extremity lymphedema and the lower extremity lymphedema. This is also the case in the genital area. The treatment of genital lymphatic follicles must also consider not only the lymphatic flow from the legs, but also lymphosomes, in the sense of the lymphatic flow from the anus. Although it is extremely gradual, I feel we are seeking some improvement in the treatment results. I would also like to discuss areas we are concerned about the moment. This is our next goal. We have a dream. Today, I introduce my personal experience and LVA journey with lymphedema treatment. I want to share our knowledge and our experience with you. We thank Professor Tommy. Thanks to his contribution, I think this society has greatly developed. Please be careful about your body and manage this club. And we are deeply grateful to Professor Cosima. Inspired by him, we are able to grow significantly. I'm very grateful to all the participants today. I did my best for today's lecture. I hope you get some hints. Again, we can zero patients suffering from lymphedema. We believe that our growth is very important for achieving our goals. We also accept foreign lymphedema patients. EAJ company support them. Please check this company and the website. Thank you for a very good time. We will upload the newest information on YouTube, so please leave a comment about lymphedema. Thank you very much. Thank you for listening to my lecture. I would be grateful if you could use it as a hint for your lymphedema treatment. We consider you to be one of your teammates. Let's continue to discuss our beloved LVA and lymphedema treatment based on the evidence and the quantification. We have no goodbye, my friends, lymphatic guys. Hasta vista, baby.